Okay, well, welcome everybody to our human-centered, sorry, just give me a second. Oh, welcome everyone to our human-centered AI seminar for today. We have Dr. Wang, who's agreed to present for us, and she's from the Center of Health Informatics at Macquarie University. Ying obtained her PhD in pattern recognition and artificial intelligence, and is passionate about developing and explaining advanced machine learning algorithms to support decision-making at clinical and diagnostic levels in health. She currently leads a project to examine clinical safety events and identify risk levels and provide interpretations of AI decisions to patient safety experts, which I think is part of the talk today. And she's responsible for development of a platform to monitor AI-associated safety risks in medical devices, and her interests involve development of safe usage of AI in clinical practice, with a particular emphasis on evaluating model transportability in real-world and explainable AI. So thank you very much, Ying.
Thank you, Michael. Thank you so much for your introduction and also the nice invite. It's great pleasure to share my research with you here today. As the slide shows, today I will talk about one of my major projects. We focus on automate the identification of patient safety incident report by their type and severity levels. And we also have a ongoing project associated with this. We try to explain the AI text classifier decisions to patient expert, try to help them verify the AI decision better and improve their efficiency to do the incident analysis. Thank you for Michael's introduction, but before we head into the topic, allow me a minute to introduce you my center and my team. I'm from Center for Health Informatics, which is one of the 3 centers from Australia Institute of Health Innovation. We located in Sydney, Macquarie University. So in our center, we have 4 major research themes. Professor Enrico Clara leads the AI implementation science team, and Professor Farah Maghrabi, her research interesting focus on the AI safety and health informatics. And we also have a Professor Shlomo Bokowaski. His team, they work more on the precision medicine, applying machine learning and data mining to all kinds of different health data. Dr. Annie Law, she leads the consumer informatics team. So I'm working closely with Professor Farah Maghrabi. Luckily, we are multidisciplinary team. So in our team, I'm a computer scientist. I would call myself as a machine learner. We also have a nurse and a clinician joining our team, and David Law, that's the only male in the picture. We have several other team members, but we don't have a recent photo yet. His research more on automation bias and cognitive science. So we're working closely to try to improve the patient safety using AI and machine learning. I've probably skipped this. Michael already introduced me. So let's go back to the topic. So I think today I focus on the classification and explanation of the patient safety incident reports. In the next several slides, I briefly introduce you what's the process to report a patient safety event and how we use the safety event report and how the patient safety expert manage this process, why the machine learning algorithm and AI has been applied to improve this process. With this project, the previous work, we have focused on developing a variety of different machine learning algorithms based on text classification to identify this report. And now we realize because all these models, they are black box driven AI algorithms. So we would like to probably provide information for the safety expert to help them verify the AI decision quickly, improve their efficiency to analyze the incident further. So in the maybe the following stage, we're collaborating with the people from the clinical practice. We will develop an AI tool, try to deploy it in a real world setting. We will run the randomized control trial first. So first thing first, let me briefly describe what's the process to manage a patient safety incident. I don't want to scare you, but this is a fact. 10% of the admission to hospital associated with the adverse event, which is the unintended injury or harm to patient. So you will receive unsafe care when you're admitted to hospital. This is known as a patient safety incident. So the reports kind of offer us some very valuable information to provide you and also experts try to understand how and why this incident occur. They became like very useful for the safety expert to do like a detailed investigation of the incident. If they group the similar incident together, they probably can provide better strategies to prevent these things from happening again. More importantly, all this license and experience we could share across hospitals, across different Australia states. That's a different level of learning. So in New South Wales, health staff in public health system, they are required to report all the incidents, including near misses and complaints. The public health system, they report their incident to an online reporting system called Incident Information Management System. It is organized by the Clinical Excellence Commission. So when the reporters, mostly are nurses and doctors, I would say majority are nurses. So when they report, they need to fill into like several structural variables, and also they need to tell a story, fill up different information factors required by the system. I will show you an example in the next slides. So the incident type and the severity level are the two major variables. It could be used to guide the patient safety expert into the different actions. How do you act on these events? How could you do to prevent recurrency? So like what I mentioned, we have a AIMS system that's run for the public health system. We also have another reporting system. This is more in charge by the St. Vincent Health Network. This is a private hospital network. So the data we used in our project also from these two reporting systems. So this is an example. So when the nurses or health professionals, they report incident, that's kind of the basic information they have to fill in. You will get an ID, date, time, of course, and so the major part, you need to briefly describe what happened, and you have to tell what kind of actions you have taken to stop or prevent this. What's the patient outcome, and have you reviewed these results? If you have a further analysis, you have to list the contributing factors. That's the overall report. But the blue part, that's the variables we used in our analysis. So we know we have this data, we have a very well system. It's like a healthcare professionals, they're willing to report. This is a very good routine already developed across Australia, even in many developed countries, which is pretty good. That is why I would say we never lack of the reports, but the most important thing, we never use this data well. The first thing is, when you ask a health professional to report all this, when you ask them, okay, you tell me what's the type of the incident, some incidents are quite obvious because when the expert analyzes them, there are more than 20 types. If the patient fell in hospital, obvious, this is the 4 incident. If you overdose a patient, that's medication error, but there are other types are quite confusing for humans and for machine. For the AI algorithm, for example, this is if you label a wrong patient that cause a wrong medication error, that's kind of two types of incident involved in a report. And also the reporters, they are healthcare professionals, they're not patient safety experts. These types are kind of confusing for them. So when the patient expert try to classify the incident, the similar incident into a basket for further analysis, if these mislabeled incidents probably can delay the further analysis for the patient safety managers. And also all the analyses so far are based on the manual retrospective review of the report. It is very like a time consuming and labor intensive. From the table at the bottom, you can see with a wide implementation of the online incident reporting system, the volume of the report just growing dramatically. That's the number we collected from the NSW Clinical Excellence Convention. Even just from 2019 to 2020, you can see there is a 5% increase every year. We had a slightly drop in 2020. That might be an effect of the COVID-19 because people had less admission to the hospital. But we see, you can see the number is large scale. So we think, how could we improve this process? How could we help patient safety experts to analyze incidents in a more timely manner? So this project, we aim to apply supervised machine learning method based on text analysis. Supervised, which means we have a gold standard labels. That's the incident noted by the patient safety expert. We try to identify the data we have into 10 primary tabs. We also try to rank the level of the risk associated with the incident. So at this stage, we focus more on how to explain the decision to the patient safety expert. Next stage, we would like to deploy the tools in a real-world setting, just to run a randomized control trial first. So I will talk about a lot about type of incident. This table tells you the basic 20 types used by the patient safety expert to triage the incident reports. Our project focuses more on the left side. This is the primary 10 types of the incident. We call them primary because like falls and medication errors, they are more like dominant type of incident. That's a majority of reported incidents. And the other types are kind of like a primary, like a focused tabs in patient safety area. But we didn't just ignore the 10 tabs on the right side. We included them into the other type. The severity level, I just mentioned before, we have 4 levels to rank how severe the incident was. It's not only just based on the actual or potential severity or the risk of the harm to the patient, it's also up to the likelihood of the recurrency. If this is a minor incident, but it has a high potential to happen again and again, it also be ranked high. For the SEC level 1, in the patient safety management process, they will trigger the immediate investigation and require root cause analysis. Normally, this kind of incident involve patient death. So all the ranking and the tabs determines how the incident is managed. So this is the distribution you can see from the data we collect. This is not a balanced data set. This is like we have the common classes, we have the rare classes. That kind of like become a challenge to develop a good machine learning algorithm. We identify 11 types. That's the 10 primary patient safety tabs, and plus we will identify all other like tabs into the other tab. That's the last column of this data. You can see it's occupied the half of the incident. That's the distribution. If we see the data from the perspective of the severity level, SEC3 and SEC4, they are quite common because that's kind of like an incident. They didn't have, they have very minor or even no harm to the patient, but that's the majority of the incident happen in the hospital. But for the SEC level 1, it is very rare, but this is extremely important. We would like to identify them correctly and trigger the further process. For us, given the sensitivity of this safety data, so when we collect the data, the incident reporting system manager, they have to de-identify the incident for us first. So it's very sensitive, involving like privacy issues, other legal issues. So even we're lucky, we get the data from 2 independent reporting systems, but the amount we have, the size of the report we have are quite limited. We only collected 6,000 incident report from each individual reporting systems. To train a robust classifier, we use a balanced data set to train the classifiers. So with this 6,000 incidents, for each type and also for each severity, we use the balanced size. But for the rest of the data, we use them as the testing data set. For the St. Vincent Hospital, for the AIMS incident, you can see we tested on the stratified data set. Stratified, that's the real world distribution data set. And St. Vincent Hospital here, that's a risk management system. It has been used as an independent data set. It never been involved in the training process. We just use it for external testing. That's the data set we have to train and to verify and examine the generalizability of the text classifiers. So the development of the AI classifiers are basically following to the traditional machine learning process. There are 4 steps. That's the work we have published so far. I will gradually introduce you one by one in the coming slides. So basically, we address several problems. In terms of the technique, we develop a multi-class classifier first. That's the classifier only identify the primary type of the incident. And the multi-label is like we observed there are multiple types of incident might be involved in a single report. So we would like to identify all the possible types of the incident. That's the extension of the work from the previous multi-class classifier. And we also noticed that because of the work the features we used are just the word-based, that's kind of like the classifier can't identify a lot of like an incident with a implicit result and cause. That's confusing classifiers. So we then try to involve the semantic-based features, and also we applied like a popular deep learning method. So let's go to the first classifier. This work has been performed probably 5 years back, so it was quite old, and we used the traditional machine learning process. And all the process is quite standard, and the features extraction, we apply the back of words model. It's basically on the frequency of these words. So when we develop the classifier, we try the different classic machine learning method. We tried the simple vector machine and the logistic regression model. When we built the classifier, we built an ensemble of multiple binary classifiers. So for the different type of the incident, we just build classifiers using 1 versus 1, which is one type against another. We also develop a different binary classifiers. That's one type against all the other types. So in our results, we found 1 versus 1 classifier after performed the 1 versus all other classifiers. We trained the different classifiers, apply them to identify types and severity. We verify the generalizability on the external data set, which is from the risk plan system. So that's the results we have. This is just to show you the F-score. You can see for the common classes, because we have the kind of the majority of this data. So the classifier identified them well. It's more like a human beings. If you see this much more, you probably can do job much better on these types. For the rare classes, the classifier, the performance is not viewable. That's kind of consistently we see the weaker classification on the rare classes. And also you can see that tabs, the 5, that's a documentation error. This is a very confusing tab of incident, because medication errors and also, patient identification errors, they're all associated with this type of incident. Even with the clinical handover, that kind of like involving multiple types of the incident. When we look into, we try to see which type has been misclassified to which. So like what I said, we identify that the patient identification incident has been misclassified as documentation errors a lot. This didn't mean classifier was wrong. It's just actually in that report, in that incident, it involves both. Because this is like classifier only identify one type. So it might think the patient identification over the documentation, but actually include both. That's the example we saw, like if a label for patient was placed incorrectly to another specimen belonging to different patient, that's 2 types of incident involved. To address this problem, we extend our work. When we extract features, we extend the feature space involving the label association, which is like we use 2 labels annotated by the patient expert for that specific incident. Other processes are quite similar, but this classifier now intend to identify the possible labels for that specific incident. We can see for the common classes, that's the performance for 2 data sets. One is balanced, another one is stratified. For the common classes, the performance are quite similar, but for the confusing types, the documentation, and also for the others type, because the others type involve all other like minor types of the incident, the performance improved. We also realized another thing when we did the error analysis, even the multi-label classification performance improved, but we noticed the incident, for example, a deteriorating patient. If a patient deteriorates in hospital, the nurses try to give him different medications or do a lot of like tests to try to save the patient life, to try to manage the patient stable. But this type of the patient, normally in the report, it always comes with a quite long list of medications. So the classifiers intend to classify this type of incident as a medication error, because that's related in the medication error tabs. You see a lot of like medication dose, this word as well. We're thinking, okay, because the features we use, the method we used based on the bag of word model, that's pretty much based on the frequency of the word. So we decide to involve more like a semantic features. We try to involve the semantics in the language. So in the next stage, we adopted the UMLs. It's a unified medical language system that's developed by the US National Library of Medicine. So for all these medical terms, they have a specific concept applied to it. But unfortunately, they don't have the specific concept for patient safety. So even we adopted these concepts, we have to deal with, like, they are not patient safety specific term concepts. They are just a general medical concept. Another tool we use is a meta map. This is a very efficient tool, could help you to label the word and the term in your narrative report into the UML's concept. But we're still happy to see the improved results. That's the 3 classifiers so far we have. You can see with the semantics, the classifier performance has been improved on these like confusing types, especially for the documentation and others type. If we apply the semantics to the stratified data set, which is a real world distribution, that's the data you expect to see when you implement your AI tools in real world setting. For the rare classes, the performance also improved. So far, we develop classifiers just based on this ensemble of these binary classifiers. So each binary classifier only can discriminate one type from another, or maybe one rank level from another. We think, how could we classify, maybe considering all these types together? So in the next stage, we evaluate the word embedding method to represent the features, and we apply to develop a CNN classifier. Given the data we have is the size we have is not that big. We develop a quite shallow CNN, only with a limited layers of the model. But we're still happy to see the performance improved. I think that is saying kind of considering all these types together, and they could identify the features, even in the narratives are quite close to each other, but when the classifier try to discriminate, they will pick the boundary carefully, try to separate the similar types. This graphic shows the result for the balanced data set, because we train the classifier using the balanced data set. So for the balanced data set, we see similar performance, but if we go to the stratified data sets, you will see a quite big improvement if we're using CNN, especially for the documentation errors and also the rare classes. That also works on the external testing set we have. We apply this method to the risk man system. If you see, this is like a dark red column, that's the performance of CNN. They can improve dramatically also on the rare classes and the confusing type of documentation. I think so far is more like a focus on the text classifier, the models we develop. If we apply these two, basically the patient safety expert just they see a report and they see a decision. The models, of course, they don't care about your model performance, but I think if we could tell them more information that could help them to improve their verification process, that would be better. If this report could highlight some words related to the AI decision, they could quickly, just capture the main contributing factors or the main thing that will save them time. That's, I think, related to the emerging kind of like research directions and explainable AI. Explainable AI, I would say there are a lot of like a variety of definitions. It's really up to the task. It's also up to the application. But I think in this project, we more focus on, we hope this technique can help human users to verify and trust the results and outcomes created by the machine learning algorithms. There are other benefits of this explainable AI. I don't go into that. So we already developed the AI models. So we're thinking, even in the literature so far, all the explainable AI techniques has been broadly divided into these three categories. People call it, if you think of from the perspective of developing AI models, it has been divided into pre-modeling explanation. This is more related to validating the data quality to reduce the bias involved in the training process. Another type is more during model explanation. That's the process a lot of advanced deep learning technique when they develop their AI classifier AI model. Meanwhile, they try to open the black box to interpret the logic of this model works, or maybe explain the features they used. And the last group more fall into the post-modeling explanation. This is like the algorithms, they develop an independent explainer. That's the separate process from developing your AI models. This type of explanation method has been used, we just provide the information from your original data set. That will help you to verify why the AI decision is made. It's direct to your data input, but it's like not directly to the development of the AI method. You probably hear the popular two methods widely used for the post-modeling models. One is LAM, the other one is SHARP. So we, in this project so far, we examined LAM. We're thinking of this. First, LAM is based on the perturbation process. So it performs faster than SHARP. Another one is LAM is classifier agnostic. LAM, when you develop a LAM explainer, it's really up to your data format rather than the specific AI models. SHARP, when you develop also an independent explainer, you have to rebuild the explainer. If you change your model from, let's say, traditional machine learning, for example, support vector machine, to a deep learning model. But LAM is basically like you can just develop the AI models. You can focus on improving your AI model accuracy, and when you build a LAM explainer, that's an independent process. So that's more like how does LAM work? Is because it's independent from the AI development. It basically, you just need the narrative of the report, and then you need the decision generated by the AI classifiers. You pick your report. Around your this report, LAM will generate a new set of samples, which is perturbated. I'll give you an example. For example, just remove a few words from your original report. And with this perturbated data set, LAM will generate a linear model. These models can weight the features they have been perturbated during this process. And then the perturbated word will be used. They will come with the weight developed by this linear model, can be used to explain your report. So with the LAM, probably you can, for our specific report, we will see the results like this. You will get the score, like how LAM think the importance of this word associated with the AI decision, and you will also see how do they separate, how this word has been used to separate these two types of your classifier. So this is a ongoing project. We still working on it. We have some readouts, but we're still doing our analysis. It's unpublished work, but I'm very happy to share what we have so far. Like what I said, we pick LAM because LAM has been heavily applied in explaining medical imaging diagnostics. So we know a lot of like advanced deep learning methods, like they have been lead the development of medical imaging classifiers. LAM has been used to verify the features, but we don't see many work using LAM to explain clinical and medical text. And LAM is kind of classifier agnostic. We have 4 different classifiers developed already. We try to see whether the explanation generated by LAM consistent across all these classifiers, because we don't see any study, even in terms of the theory of LAM to generate explanations. We know this is classifier agnostic, but we don't see any study actually investigate this feature of LAM. And the evaluation of the LAM so far based on the visualization is eyeballing all these explanations, and then ask the expert to see, for example, in the medical imaging area, they try to see whether the regions are making sense to them or not. Given my background, I'm more focused on to evaluate the robustness and also generalizability of the LAM model generated explanations. Once we think the LAM generated explanations are robust, generalizable, and the next stage we will involve like humans and users and try to evaluate whether they favor these LAM explanations. So far, a lot of people, LAM is the process is simple and fast, but people criticize the uncertainty and the randomness of the explanations generated by the LAM during given the perturbation process. So in our experiment, we also try to examine this point. So all the data settings we used to develop AI classifier is also being used to create the LAM explainers. When we examine the LAM performance, we try to optimize the LAM parameters. LAM do have several hyperparameters because you have to pick, for example, the feature size, which means how many words you would like to use to show to the users. This is a very tricky parameter because you don't want to highlight many. It didn't help at all, and you don't want to miss anything important if you just use a few. So we examine that size of the top word. We also examine the kernel size. This is a size of the neighborhood. It's when you perturbate new samples, and you have to decide your neighborhood, how big you are going to perturbate to generate new samples from your original report. Another thing is whenever you try to calculate the distance between your original report with the new report, we adopted a lot of similarity distance methods, try to see which one is best. LAM is local, so it's more like all the explanations only valuable or meaningful to your individual specific report. To evaluate the robustness of the local explanation, we also generate the global explanation. We group the local explanation from the different type of the incident, try to see whether each individual local explanation actually quite close to the global one. We also evaluate the LAM classifier agnostics. That's a consistency of these explanations across the 3 text classifier we already developed. We assess the generalizability across 2 reporting systems we used, which is AIMS and RiskMan. So this is, we do have a lot of results, but I think due to the limited time, I only show the basic finding and observations we have so far. Lyme is local, yes. We see the variation exists. For the same report, you may see quite like very minor variation generated if you rebuild the Llama explainer again, but the most significant features are quite consistent, which means, yes, it is local, but the returned explanation is like consistent. We also noticed Lyme perform more robustly to explain the incident report correctly classified by the text classifiers. It is independent to the text classifier, but when Lyme generate explanations, it's also based on the AI decision. If your AI classifier misclassify this incident, of course, you don't expect the explainer could return you a highly related word to the AI decisions. That is why in our analysis, when we evaluate the robustness of the general explanations, we split the report into two groups. One group is classifier correctly classified. Another group is the classifier misclassified, but misclassified consistently by 3 classifiers. That means we have 3 classifiers. If 3 classifiers all saying, okay, this report, I think, is medication error rather than documentation error. We would like to see how Lyme explain this situation. That will help us to improve the AI accuracy as well. But we do have a lot of challenges. First thing is, whenever you try to evaluate the quality of the generations, the first thing we face is we don't have gold standard explanations. Patient safety expert help us to verify the annotations, but this is also like, manual process. We're working on that. So far, we only can use the global explanation generated, pulling from all these individual explanations as a temporary gold standard to evaluate the quality. Another thing is, how do we select appropriate size of the explainable words? Incident report is the average length of the report is around 75 words. So you don't want like 30 or 50 top words returned. It didn't help at all. And the different similarity methods also return us different results. We have to pick which is the best. Within the Lyme Coulson, this is by default use the methods. So we use Coulson as well, but we also use other similarity methods. If I have further results, and I'm happy to, if we have a chance again, I'll share more with you. Yes, I'm also working on several other related projects. One of my other project is we monitoring digital health safety events. It's like we know health IT has been widely used to improve patient safety, but meanwhile, it causes another issues as well. For example, if you receive many alerts, that's kind of give you a fatigue of the alert, you probably just ignore all this alert. That will lead you to a wrong decision. And sometimes more and more AI technique has been applied to in the medical device. For example, you probably hear a lot of AI medical device help you to screen the patient. Once they found any positive results, they will refer them further to the specialist. But given this AI accuracy challenges that cause a lot of problem when people using these medical devices. And most importantly, when they commercialize this product, a lot of users, they don't really understand the AI output. So another project, we try to monitoring all this like AI or machine learning safety associate events. If you are interested, we'll welcome all kinds of different ways of collaboration. Yeah, I think I stop here. Open to questions if you have any. Thank you.
Thanks, Ying. If there's anyone in the audience online, firstly, thank you. Anyone who's in the audience online, if you want to stick your hand up, feel free to if you have questions. I mean, I can start, Ying. At the end, you were talking about gold standard explanations. So, I mean, I guess what you're comparing against is human classification of these reports to check as your kind of baseline. Have you considered or got people to not just do the classification, but explain why they're doing the classification? Because that may inform how you would want to show the reasons for your automated classification to them, I guess.
This is a very good question. Thank you. So we were thinking of this, but it was a quite like complex process for the patient safety expert to analyze it. Like what I said, they could label this incident into different tabs, and they have it's more like probably related to this graphy or the diagram, the work you're working on. Like they have a process to decide what's the like a root cause, and after this, what's the next, following cause. Even there is a process, but for the different safety expert, they probably respond to them slightly different, but it won't has a major effect on the management of the incident. For example, if you it's not misclassify, if you label these two tabs differently, swap the primary and the secondary tabs, and you also have other variables and information to help you to decide to manage this process. But for our project, this is just the very beginning of this process. We try to classify it rather than doing this detailed analysis. Before we were thinking, could we identify contributing factors? And then we realized probably so far at this stage, the machine can't handle it. And also given the data we have, it's quite limited. Even we never lack of report. You see the numbers. But the thing is, sorry, I just ran out of battery. But it is really hard for us to reach this data. The 6,000 report we use, it has been more than 5 years with us. Recently, we got a chance to collaborate with the people from patient safety area. They willing to share more data with us. Probably we can think more from there. But so far, we limited to the data we have and also to the very complex analysis process they actually used by the patient safety experts.
Okay. And while you're speaking about the data, you said that you had access both to stuff from incident management systems and also this risk man, and you showed how the performance kind of differed a bit on those. What's the relationship between those, or the kind of fundamental differences in the reports in those systems? Because that might explain, I guess, why the performance differs. Are they both just equivalent systems that are used in different health services?
It's quite similar. Like we pick the type of the incident and the severity level. That's the commonly used variables when you report incident. Even the worldwide, this also suggested by the WHO. That's also the variables used in American as well, and also UK. So in terms of these two variables, we try to identify. It is consistently widely used in the incident report worldwide. But in terms of others, they are slightly different. But because we focus on the narratives, we focus on the text. So when we pull the text, we normally, another common variable is like a description of the incident. They always give you a space to describe what happened. That's with every single report. So we extract mainly the text from that variables. But with other different systems, some systems, they probably ask you to tell us more about what kind of actions you have conducted or taken to stop or prevent this incident. And with a further analysis, you will see the patient outcomes. These variables are quite it's like maybe different across systems, but we focus on the text. So if these variables were available, we will extract from these variables just for text. So far, we didn't use any of the structured information. Even when you report, they ask you to select one of the incident types from the drop-down menu. It's like you have to label one of these 20 tabs. We didn't use that information because we noticed the poor quality of this label by the reporters, by health professionals, and also like they describe more in the when they describe the whole thing.
Yes.
Or other these things, they probably didn't pay much attention.
Yeah, which actually brings me to my last question, which is just, I'm interested in how exactly this information would get used if it was to be put into, you know, if your approaches were to be put into practice and adopted by a health service, who benefits from these implications? Because I understand some of these systems, you know, the clinicians are entering details of the incidents, but as you say, they might not care about the labeling because once they've entered it, they never see it again. But presumably maybe hospital management cares because there's they look at the overall health of the organization and want to avoid issues like pressure injuries or falls or medication issues, as you say. Or maybe there's penalties or things that are that affect the hospital. So I guess, like, how much do you know about who would be the kind of consumers of this technology, and have you talked to them much?
That's a very good question. Thank you for that. So there was a silent period of this project. That is because you know, like, we're looking for the real world use of this. So when the healthcare system manage incident in hospital, they have a patient safety manager. So they are in charge of this incident reported to them. So that is why you can see the types and the severity levels. So every day they receive probably multiple reports. They will work on the incident with a priority. Like what I said, if this is a SEC 1 level incident, patient gets involved, definitely you need action now. in the investigation now. And the patient safety manager in hospital, they also responsible for collecting all the other necessary information. When they report, they just briefly describe what happened, and all the other information they have to collect. This is just the hospital level, but if you go up to the the state level or even the national level, it's more like patient safety experts. They focus on, for example, whether there is a new type of incident. It's different from other types. That's more from recently from the health IT area. Because more and more hospital in they using the digital health, and it's different from the human workflow that cause a lot of problem as well. There is a very tragedy happened several years ago in Macquarie University Hospital. That's a new system just implemented it in hospital, and a doctor kind of overdose a patient. That's it's very severe thing. The patient died because he opened the two windows of this patient, and he was thinking close patient with a small dose, but actually he didn't. Probably the system didn't do it well. He tried to write a different dose to another patient, but the system overwrites another patient dose to the previous patient that caused the death of the patient. There are some new types of the incident, and also the patient safety expert, they pull all these similar incidents together. For example, if this is all these 4 incidents, and I would like to see what's the contributing factors to this incident. Is there anything changed from previous understanding? Is this related to the new interventions or even the health system policies? Whether there is any change or update? That will help them to do group analysis. If we could efficiently group all this incident together, it's like try to help them to respond to the incident in a very timely manner, quickly. Another thing is to improve the learning, to improve the active learning or continue learning from this incident. Because before, they have to do it manually, one by one. It's now they can, if we could classify them correctly, they can just focus on the specific type. I would say this is more like a hospital triage process. Our project to triage this incident first. If we could help them to triage better into the correct type of the incident, they can just focus on the further analysis, more group level analysis across much higher levels.
Okay,
so we we collaborating with more people in the patient safety area rather than the healthcare professionals. They understand this report, this incident. We're working with them. They help us to label this incident. That's provide the gold standard for classifier to examine the performance. And we also, whenever we identify anything new, we will send them back. They will verify and will evaluate for us.
Okay, great, thanks. We only have a couple of people online now. More, Agnes, don't know if either of you had questions.
Oh. No, not at this time, thank you. But thank you, it was really, really interesting. I've had some experience with Lyme, so this is putting it in another perspective.
Thank you. So may I ask, how did you use Lyme? Or?
So what we actually wanted to do, wait, okay, here we go. So what we actually...
I might stop the recording anyway.
Oh, yeah.